We have a few minutes left, so I'll actually just switch to esophageal squamous cell carcinoma. And I will not ask everybody the question what they will do if somebody is Claudin positive and PD-L1 positive. You can watch our roundtable from 6 months ago. The answer remains unchanged. We don't know. Esophageal squamous, there's not a lot of new, I don't think, practice-changing data here, but just because we're talking about all upper GI cancers, what is your approach in the first-line setting? What IO do you use? We have 3 IOs approved now, right? Tislelizumab, nivolumab, pembrolizumab. What is your approach, and do you use biomarker to select? I'll start with you, Vince.
Yeah, I mean, we generally employ a similar approach in the metastatic setting, metastatic esophageal squamous. We generally employ a similar approach to adenocarcinoma in many regards. FOLFOX, Nivo, FOLFOX, Pembro. There's also consideration for other chemo backbones, leveraging the head and neck data. But of course, with tislelizumab, I've personally actually never used it myself, but it's great to have another option. It's interesting from the data that the hazard ratio for overall survival seems to be a little bit better compared to the Keynote and Checkmate studies, but I'm not sure what to make of that per se, because in multiple tumor types, multiple randomized phase 3 studies, our understanding is that these anti-PD-1 inhibitors are generally the same, but if anything, that might push me towards employing tislelizumab.
I do think the chemo backbone, I'm not entirely sure that it's clinically different, but some of the randomized trials used a cis-5FU approach instead of an oxali chronodosed approach. Generally speaking, squamous respond incredibly well, especially in head and neck compared to adenos. So I don't think there's a difference in efficacy, but I think there's clearly a difference in side effects. But cisplatin is very challenging to take.
Does anybody use Sorry, Nataliya. I was just going to ask the panel if anybody used Ipi-Nivo.
Outside of an MSI high, I haven't.
No, I mean the only variation I have is if young person, maybe I give FOLFIRINOX plus immunotherapy. I've done that, but even then I'm not convinced necessarily it's a better way of doing it compared to a doublet.
There are some questions that I personally haven't answered, but it goes back to the nuances, I think, between FLOT and FOLFOX. What do you guys think about tolerability, for example, in a marginal performance status patient with squames, choosing dual immuno versus cytotoxic chemotherapy?
Do you have thoughts, Jun?
I think Nivo-Ipi can be sometimes hard to, non-trivial side effects as that as well.
And you can't predict them, and they can be
Yeah. I think the problem is that if you look at response rates of Ipi-Nivo versus chemo alone, they are like high 20s. When you use chemo IO, response rate really go up when you combine. And that Kaplan-Meier curves is this like classic Kaplan-Meier curves with IO alone. People do worse at the beginning and then they get better. And these patients, at least in my experience, the squamous cell cancer, patients with squamous cell cancer, they're so sick. They have comorbidities, they have dysphagia, they sometimes have fistulization disease. It just makes everything so much more difficult. You need response.
And I've also,
yeah, one shot.
Based on, I apologize, I'm ahead of myself, but I can't help it. Based on my experience with another air digestive cancer, squames of the head and neck, there's discussions, of course, about using cis 5FU versus, say, weekly or Q3 week carbotaxol. So another bailout could be modifying your chemo backbone to something like weekly platinum taxane, and those have also been used as a chemo backbone in other studies.
And I fully agree with you. I mean, I have a patient who's elderly. I'm going to give weekly carbotaxol because in a metastatic disease, quality of life becomes an integral part of your thinking, right?
Have you used tislelizumab with that backbone? Or?
I haven't, but maybe I can get an idea to use it from you.
I mean, because this is the only study in Western population that actually use the taxane-based chemotherapy backbone.
Can I? Do you think I'll be okay to use it in terms of the coverage?
It's on
approved.
guidelines. It's
For
approved.
carbotoxin.
Yeah. It's
Okay,
for
well,
it's yeah. It's
This,
it's
this
with a
was great. I
taxane.
learned
Yeah.
something.
And then they've also updated their dosing too from
Yeah.
the 3 weeks to 2
They have
weeks,
different.
which I think works out. And
That's
just
wonderful.
just to add to that point about I think it's a great thing we have 3 category 1 IO platinum-based combinations in both squamous cell and adeno. And I think just to tease upon some of the perhaps the emerging data, there's some subsets from the TISLE data that suggest there's some peritoneal subsets and some liver-only subsets that when compared to the checkmate data, they have some too, but it seems robust, and that's something to look into about the activity and the uniqueness of TISLE. It does have a different MOA than the other PD-1 inhibitors too, with the FC receptor portion. So just emerging data to keep an eye out
Yeah,
for.
absolutely.
I mean,
And it is a partner, by the way, in zanidatamab. This is the IO used in the Horizon study too.
I think we have to have an open mind. I mean, I'm one of those people who always thought, PD-1, PD-L1 are all the same. I think we have to start thinking that they may not be the same. And we have to, at least we have to have an open mind about it. That's
I'm
what saying.
intrigued biologically, although I'm certainly at best a junior clinical immunologist, but teasing out this FC receptor, not only the glycosylation on the antibody, but potentially these FC receptor variations will come out.
Well, this has been a great discussion. We are at time, otherwise we could still sit here and talk, maybe with lunch for another hour and a half. But it's been a great discussion. I think there's also a lot of exciting data coming. I think, maybe next year we'll be talking about bemarituzumab, an FGFR2 antibody, and we'll make it even more complicated how we pick treatment selection. But I think it's good for our patients to have more options. So I would like to thank everybody for making my job moderating it easy and having a great discussion. And thank you, GI Oncology, for inviting us.